Welcome colleagues, I'm Dominika Zentner, an adult cardiologist at the Royal Melbourne Hospital where I run the Cardiac Pregnancy Clinic, and I'm also one of the cardiologists in the Adult Congenital and the Cardiac Genetics clinics. Congenital heart disease is the most common abnormality, occurring in about 1% of live-born babies. And most congenital heart disease appears to be sporadic, although there's increasing recognition of a genetic contribution. Genetic counselling, however, is essential for everyone with congenital heart disease. So if you've got any doubts about the person in front of you, I think it's really important to refer them. In very broad terms, progesterone-only contraception is safe for women with congenital heart disease. So for example, Implanon and Mirena. Depo-Provera is an alternative, but must be given every 3 months. And the mini pill is also able to be used, but it does have a small window of administration. The oral combined pill has some limitations around safe use, for example, for people who have had or at increased risk of venous thromboembolism. However, the prothrombotic risk of pregnancy, though for a shorter period of time, is higher than that associated with a combined pill. And so sometimes after conversations and shared decision making, we still accept the oral combined pill, although in some particular patients only in the setting of accompanying anticoagulation. Remember also that many of the drugs used in pulmonary arterial hypertension are both teratogenic and can affect the efficacy of contraception and consequently the advice around double barrier contraception in that setting. Pregnancy is an increased risk time for the heart for all women. And pregnancy in women with congenital heart disease is therefore not only at that increased background risk for all of us, but also at risk from their CoHD diagnosis and its sequelae. Whatever complication or sequelae has previously occurred is also more likely to occur again in pregnancy. And additionally, there are associated concerns about possible congenital heart disease in the baby and an increased rate of smaller and premature babies. Concerns about maternal risk lead cardiologists to recommend reduced maternal effort with delivery. There is a potential for increased morbidity with these, as with any intervention. We also need to recognise the potential for anxiety and psychological distress. All women with congenital heart disease contemplating pregnancy should be seen by an ACHD cardiologist pre-conception. Our role is to provide information and advice and explain risks to the best of our knowledge. Women may choose to conceive, however, even if they've been strongly advised against it, and then it's really important that the best care possible be provided. Conversations about reproductive health should start early, before adolescence, and provision of both general and individualised pregnancy risks occur. The former certainly by transition, but the latter is a potential conversation, I think, at every cardiology review in adulthood. Knowledge is power, and again, if you're not sure what to advise the people in front of you, please refer. Reproductive health education should begin before adolescence and continue as part of transition of care programs and in adulthood. All people with congenital heart disease should have genetic counselling, and some should be offered genetic testing pre-conception. All women with congenital heart disease should have preconception cardio-obstetric counselling by a cardiologist knowledgeable in adult congenital heart disease. All women should have up-to-date tests. The preconception counselling visit should lay the foundation for where a future pregnancy can be managed and have a clear means of contact for that woman and her GP if indeed the plan is to return to a specialised service for pregnancy care. Most women with congenital heart disease who wish to be a parent can be supported through pregnancy to delivery.